So thanks again. As Juliet said, my focus is really on high-risk populations for TB globally. And most of my work is predominantly in South Africa and China, and some work in Brazil as well. So I work mostly on TB in children. I work with people with HIV, incarcerated people, and then people with non-communicable diseases that may put them at higher risk for TB. Today, I'm going to talk about TB in young children. This is a topic I've been working on since my time as a PhD student at UGA, actually, where I first got my start on this topic. I'm going to talk today about some of the triggers that may be at play for progression of TB infection to disease in young kids, but I'm going to specifically focus on viral infection, specifically cytomegalovirus, and a potential relationship between cytomegalovirus and TB, and some of the implications of some of this work, and then some potential next steps. So I'm pretty relaxed speaker, so if you have a question or something, please write it in the chat or just feel free to interrupt me. And Juliet, if you could just let me know if there are connection issues, just like feel free to interrupt.
Yes,
or send me a text or something.
All right, thanks.
So I'm going to give a brief introduction of some of my previous work that led up to the project that I'm going to present. Much of my work over the past maybe 5 to 7 years has been trying to understand the risk of TB in young children after exposure and after recent infection, specifically in high burden settings. And I think much of the work in the TB field on this topic has been more in the older literature. This is some work that was published in 2005 by Ben Murray and colleagues, where he really tried to synthesize all of the data from the pre-chemotherapeutic era, so before 1950. And he tried to estimate the age-specific risk of TB after primary TB infection. So what is the risk of developing TB disease after infection? And this is kind of a synopsis of what he found. He found that the risk was highest in very, very young children under 1 year of age, and gradually decreases with age. So this is pulmonary disease, huge risk below 1 year of age of progressing to TB disease. And then there's this huge dip after 1 year. And then it keeps dipping. And then later on, after 10 years, there's a slight increase in risk. And so this is sort of actually what I was taught when I was a student, that this was the risk. And this is based on more of the older literature, about 100 years old. And so really it's a U-shaped risk curve. And this trend is maybe even more obvious here. This is some work by George Comstock in 1974. This was in 82,000 individuals that were PPD positive, so tuberculosis skin test positive, so suggesting that they had that they were positive for TB infection. This is in Puerto Rico. And you can see here that the risk of TB is greatest in the youngest kids. And then there's this huge dip, and then an increase in adolescence or young adulthood again. So pretty similar curve, actually, than from the last one. And so a lot of my work over the past 5-6 years is to try to replicate these findings using newer contemporary data. Do we find similar results in recent times, or has the situation changed? So some of these data that I presented are maybe 100 years old, and some of them are maybe 50 years old, around there. And a lot's changed since that time. Now we have HIV. There's preventive therapies available. There's a lot of drug resistance. There's TB treatment is a lot more effective. So there's a lot of changes that have occurred over the past 50 to 100 years in the TB field. And so the idea was to say, okay, can we replicate this? What does it say? And can we compare it to some of this older literature? So this was some of my work, this large consortium work, a lot of people involved. Actually, a few people at UGA, including Chris Whalen, was involved. That this was an individual participant meta-analysis of 46 different studies. And what that is basically trying to collect all of the global literature, all of the global data on the TB risk in young children that are exposed to someone with TB in their household. So this is basically if a study was published that was a contact tracing study in children with exposed people in the household, we reached out to that group and we said, well, this is our research question. This is what we're trying to ask. We want some newer data to try to understand TB risk in children. And so 46 different groups came together and pooled individual level data to try to understand TB risk in young children. And so it was huge collaborative effort. It was really amazing how many people collaborated. And this was included about 140,000 children that were exposed to someone with TB in their household from around 30 countries or so. And we found that the risk, this was the main question we were trying to ask to replicate those old studies. What is the risk of TB disease after infection? So after a positive TST or IGRA test is how we define that. And you can see here that this is the 2-year cumulative incidence of TB after infection, which was defined as the baseline contact tracing visit. And you can see that the risk is very high in young age, around 19% below 5 years of age, which is really a huge risk of TB, and then dipped after 5 years of age to around 8% in these children. And then it continued to be around 8 to 10% throughout the rest of childhood, or even into adolescence and early adulthood. But still really high risk, even in these older age groups. So still 8 to 10% risk of developing TB 2 years after exposure and after infection. It's just super high. And so I think it's interesting to compare this with historical data. It's a little bit lower, but still really high, and still sort of confirmed that the risk is very high in children after exposure. So then I tried to replicate these results prospectively. I said, okay, this is using not older data. This is using previously published data. But what is it really like? Can we replicate this prospectively with a prospective cohort? And specifically, I have been working for the past 7-8 years or so with a group in Cape Town that work on pediatric TB. How does the risk of TB in young children look in Cape Town is what we wanted to ask, or sorry, in South Africa, where this is a place where we know the rates of TB are very high, among the highest in the world, and HIV infection is very prevalent. So depending on where you are in South Africa, there's a range, but in this setting, it's around 20 to 25% HIV prevalence. So very high. So this is, I've been working with the Dry Consumed Child Health Study for a number of years. This is Heather Czar is on the right-hand side. She's the PI of the cohort. And she's been working on this cohort for over a decade now. This is a cohort I'm going to speak to you about today. It's recruited from Paro, which is about an hour northeast of Cape Town. And the study communities are fairly low income with poor housing. And all participants are access care in the public sector from one primary hospital that we partner with. This is a community that is pretty, there's not a lot of migration in and out. It's a pretty stable community. And so that's one of the reasons why this location was selected for this really long-term follow-up cohort. I'm going to talk to you a little bit more about the study design and about the study results. And this is a birth cohort study. So this is basically it was a recruitment of pregnant women that were 20 to 28 weeks gestation. There were around 1,200 pregnant women that were recruited and enrolled in the study. And then a birth cohort basically follows these women until they give birth, and then follows both the mother and the child in childhood. And there are infant birth baseline evaluations, and then there's follow-up for a disease. This, one thing to mention is this is not a TB specific cohort. This is actually a cohort that tries to do surveillance on a number of different diseases. And there's a range of different groups working on different diseases within the cohort. So there's groups working on HIV exposure in children. There's groups working on pneumonia. I think pneumonia is a big focus of this cohort. And then there's a group working on mental health, and then TB. And the TB group is the one I'm a part of and really focus on. In this cohort, there's 22% maternal HIV infection, but very, very low HIV infection in the kids. There's a really strong ART program, which is very effective at preventing vertical transmission of HIV from mother to child. And so I think we had one child that was diagnosed with HIV out of the 1,200 or so, which is, it's a shame that any child's really acquired HIV, but generally it's pretty good rates considering the very high maternal HIV infection. There was very high retention rates, and I think part of this is because that this is a pretty, there's not a lot of migration from these communities, and I think that's part of the reason why there's very high retention. And so I'm going to talk about follow-up, but now these kids are around 8 to 9 years of age, and there's fairly good retention up even now. And there was really intensive sampling early in life. I think the long-term goal of this cohort was to do long-term follow-up, but to understand early life risk factors for disease. And so most of the cohort was intensively sampled and followed during this early phase from birth to 6 months, and even from birth to about a year. There was a lot of different types of sampling in this early time period. And these kids, the mothers and the kids were both actively followed up for TB disease. There was at sick visits, at regular visits, each of these time points was a different study visit, but then also during this time there was sick visits. These kids unfortunately had a lot of, I think one thing to mention is this is a community-based cohort. It's not recruited based on any risk profile. So any high risk profile, it was randomly selected from the community, but there was a lot of, there's a lot of morbidity in this cohort, as you're going to see in a little bit. Tuberculin skin testing was performed at 6 and 12 months, and then annually until 5 years of age. And TB disease was continuously evaluated at regular and sick visits. After the first year, the cohort was a little bit less intensively followed. It was followed, there was regular visits every 6 months until 5 years of age, and actually even further on. But there wasn't visits every 6 weeks or so, which was which is more of the intensive sampling that occurred early on. This is up to 5 years, but as I said, the kids are now 7 to 9 years of age, and I think one kid reached 10 years of age a few months ago. So throughout these visits, if a child was suspected of having TB disease, sputum smear specimens and induced sputum and duplicate was collected, TB culture and expert was available from all children with a TST in duration above 10 millimeters, suggesting TB infection, and also if a child was suspected of having TB by a TB clinician. Chest x-rays were taken in all children with suspected TB. And I think there was really high TB rates in this cohort. I'm not sure what the PI, Heather, what her prior was, her expectation was. I think she thought there was high TB, but we found very high TB rates, maybe even more than she or I expected. So to date, there have been 96 TB cases diagnosed over the follow-up. Under 5 years of age, the rates were around 1,500 cases per 100,000 person years, which just to, if I want to put that in perspective here, the rates in the US are around 3 per 100,000 person years. To give you perspective with the US, the rates in the background, South Africa are around 400 to 500. Or sorry, I think even a little bit less than that, but much lower than these rates here, many times lower. And so we thought maybe this was, I think our first thought was maybe this is overdiagnosis. Maybe that some of these cases are being overdiagnosed, but actually we found high rates of microbiologically confirmed TB through expert, through culture, through smear. I think we had a lot of microbiological testing, and that really helped to also look at this from that lens. And so I think that sort of gave us some indication that there really probably is very high rates in this setting, and it's not overdiagnosis. And so we wanted to look at this question prospectively, and we found very high rates of TB, especially early on in life, and that really dipped as these children aged. You can see here some of the rates in the first year of life, and then very high rates 1 to 2 years of age, 2 to 3, and actually these rates even down here in this older, relatively older childhood age are still very high. But we're seeing that same dip that we saw when I showed you the historical data and when I showed you some of the pooled case contact data. So a big dip after the first few years of life. This is a population, especially because it was part of a study. We really wanted to make sure that kids had access to vaccinations, access to the primary care system was giving available access to vaccinations like BCG. So this is a heavily vaccinated cohort in terms of BCG and some other vaccinations. So that was another question is, I think sometimes we think in the TB field, BCG vaccination is how to protect children for TB. In this cohort, it was insufficient to protect these kids from TB. So that's another question. So I think one thing that really stood out to us is after analyzing these results, what is causing so much TB in these kids from this cohort? What exactly is going on was our next question. And so I think that led to a few more series of studies to try to understand what's going on exactly. And so these rates, these general trends confirmed to some extent what we had seen in the historical work, that the risk of TB is really highest in the youngest age groups. And clearly we were a little concerned about these very high rates in this cohort and wanted to try to understand a little better. And so we had several hypotheses after we published this work. And one of the main hypotheses we had that I'm going to talk about today was viral infection. We thought potentially this could be one reason for this really high risk, especially in the very early age groups. So just to explain the hypothesis a little more, viral infections are very common in the first year or two in life. I actually have a 8-month-old daughter who I can confirm that's true. She has had many viral infections in her first year. And this is very common really all over the world, really. So, but there haven't been too many studies that have looked at viral infection and subsequent TB risk. There have been a few, usually in high-risk selected samples. Typically, these studies haven't been done prospectively. And so this was one of the first hypotheses we wanted to try to understand and test. And I'd say this hypothesis is not really new either. This is sort of something I'm coming to learn, is that every time I have a hypothesis that I think is new, someone has thought of that before. Maybe not recently, maybe, but there's like a history of really smart people in our field, in a lot of these scientific fields, that if you go back, you end up realizing that you're thinking about things that people have thought about before. And so this hypothesis, to some extent, goes back to George Comstock and many others. And the idea, I think, is really this idea that this two-hit theory of TB progression, where you're exposed and potentially infected with TB, and that is one hit. But really you need a second hit, either before or after exposure. And so this is some of George Comstock's work. He sort of came up with this idea. He worked in many fields, not just TB. He also worked in many different fields. And so he said, TB also affords this interesting analogy with the two-hit theory of cancer pathogenesis. The tubercle bacillus is the necessary or initiating cause, but some reduction in the body's resistance, probably decreased cellular immunity, is undoubtedly the sufficient or promoting cause. So it's this idea that you need a second hit to really progress to TB. And this is a really nice, more recent figure displaying this idea further. Really, you can see here there are multiple types of secondary hits, as George Comstock described them. There are predisposing hits, which are really the typical ones, I think, in our field that we really focus on. So diabetes is a predisposing hit. It's a predisposing immunological hit. HIV is another one. Alcohol, malnutrition. These are all things that really are likely predisposing your exposure many times. But there are also precipitating hits, which occur or may reoccur after infection, and can maybe destabilize a potentially controlled infection. And I think viral infection would really go into this category, precipitating factor. And so you can see here, this is a really nice figure. You can see here, like here is predisposing factors could go here. This could destabilize, or this could destabilize an infection, or lead to progression to disease. Or you could have a TB infection here, and then there are possible precipitating factors that it's like causing a hit here, causing a hit here. For example, viral infection is an example here. And this could lead to destabilizing of your your immunological makeup to potentially lead to progression to disease. This is the theory, at least. This is the hypothesis. And so this is sort of the hypothesis we wanted to look at with viral infection. So I think an important question is, why did we want to look at cytomegalovirus specifically? And why did we want, of all the viral infections, why were we very interested in this one? I think there's a few reasons. There have been a few studies that have suggested a relationship between these two pathogens. Most of them retrospective or cross-sectional, that and so there is some early data that has suggested there's a relationship here. CMV, just to give you a little bit of background, CMV is typically asymptomatic in early childhood. But once people are infected, they often remain with this latent and chronic infection that can later reactivate in their lifetime. It can really drive immune activation and dysfunction, and it increases lymphocyte and cytokine producing inflammatory T cells, which we know are there's an immunological relationship with TB. And so there's some immunological overlap with CMV and TB in terms of impact and progression risk. And so, as I said, there's been a few observational studies that have suggested a relationship. I would say the evidence overall is lacking. And I think the other important, maybe interesting reason why we had this hypothesis is that CMV and TB have really similar epidemiological curves in terms of when they occur in populations. So you can see here, this is the George Comstock figure that I showed earlier in the PowerPoint. Huge risk early in childhood, big dip in adolescence, and then in adolescence it increases again. This is a figure on the force of infection of CMV. You can see this huge risk. You can almost not see it because it's so close to childhood, but huge risk early in childhood, huge dip in adolescence, or even before adolescence, in later childhood, and then an increase in adolescence probably from reinfection and re-exposure to CMV. So you can see that these epidemic curves are very congruent, very similar. And so this is another reason why we had this hypothesis. Maybe these two pathogens are co-occurring together. I'm not talking about hypothesis data here. I'm talking about real data. And I talked a little bit about some of the immunological overlap here in terms of innate and adaptive immune responses. I'm not going to go into this because I'm not really an immunologist. And if you ask me about this, I would defer a little bit, but I wanted to mention that there is an immunological overlap between these two pathogens. So I'm going to talk a little bit about this paper. It was published last year. I'm not going to be able to cover everything, so if you want more information, you can go find that paper. And also, I'm happy to take questions after as well. So just to give you, this is the same birth cohort that I've been talking about. I'm going to talk a little bit about how CMV was tested in this cohort. CMV was assessed in children through CMV-specific DNA using nasopharyngeal swabs. And really, what we wanted to look at was that heavy, intense sampling in the first year to year and a half of life. As the way to get at CMV infection. The same samples were taken at birth and then multiple times throughout the first 2 years. Most children had several CMV tests. And so we included children if they had at least one CMV measurement in the first 2 years of life. And this was around 963 infants were included in the final sample. 112 didn't have a valid CMV test. 90% of the CMV tests were performed in the first year of life. So really this is, did they acquire CMV in the first year? And then there was a mean of 7 CMV measurements per child. So these tests, there's definitely serial sampling where if they tested negative and then they tested positive, then they were positive. So we had a lot of serial samples for these kids. And we found the cumulative incidence of CMV in the cohort reached around 40% at 1 year of age and 45% at 2 years of age. You can see that there's this large jump from 6 weeks of age here to 24 weeks of age here, from around 3% to 21%. But it's a continuous rise in cumulative incidence here. I'm going to talk a little bit about this jump and potential hypotheses for this in the next slide, actually. And we suspect, at least from this data, that the breastfeeding is the major pathway in which CMV is being acquired by these young children. Breastfeeding was the strongest risk factor for CMV in early childhood. This figure shows the odds of CMV positivity at different time points in relation to breastfeeding. You can see that there was an increased effect of breastfeeding depending on how long you breastfed for. So there was some indication of a dose response here, that if you breastfed for longer, you had more chance of having CMV. But it was highly significant no matter what time point we looked at. We looked at other routes of transmission as well, or proxies for these. So for example, if an older, I think another hypothesis of CMV transmission is maybe young kids are getting it from older siblings, potentially. But we found that, larger households or households with a lot of children in them wasn't associated with an increased risk of CMV in the first year or two of life, which was a little surprising to us. So we feel this is the major pathway. There may be other pathways as well that these kids are getting CMV from, but we feel this is maybe the major driver. And we found that there was a very high risk of TB in these kids that were acquiring CMV early on. This is the, if we take all follow-up throughout the entire cohort with no restrictions on follow-up, kids that acquired CMV before 1 year of age were over 2 times higher risk of developing CMV in their first 7 to 9 years of follow-up. So you can see here, this is a hazard curve. This is the risk of surviving TB disease. So it's basically a hazard of TB disease. And you can see here that this CMV positive group in kids had a much higher hazard of acquiring TB than this one of not acquiring CMV. And I think it's a little interesting. There's a separation of the curves here at about 6 months or so. And we don't know exactly why this separation occurred. My hypothesis is that enough kids are acquiring CMV by this time point where the lines are separating. It takes some time for enough kids to have acquired CMV. And if this association is really true, and there's probably takes some time before you can actually progress and be diagnosed with TB. It probably takes a bit of time. And so that's one hypothesis that we don't really know for sure why this is the case. But I think there is, if I go back here, there is a bit of an issue with this specific analysis in that the exposure and the disease are not separated to some extent. CMV is acquired before 1 year of age, and we're following up TB throughout the entire follow-up, including 1 year of age. So maybe TB and CMV are co-occurring, you could say, from this analysis. Maybe they're occurring at the same time. And so really, I think another part of this analysis was trying to separate as much as that we could the exposure from the outcome. And so this next analysis is CMV acquired before 1 year of age and TB incidence restricted to after 1 year of age. And you can see that actually the hazard increases here to 3.2 In the last one, it was 2.3. And so we're as much as, actually, we can do it more, but, and I'm going to show on a slide some more of this. The exposure and the disease are separated here. And so this is adjusted for a range of confounders. It's adjusted for TST conversion status, for pneumonia, socioeconomic status. This is a generally poor socioeconomic study population, but we controlled for it. We also controlled for sex, and we tried to explore other confounders and see how it affected things. And generally, there's no impact of confounding here. We could have been missing something, some variables, but generally with the information we had, there was no impact. We did see some indications of a dose response based on the viral load here. And so the way that this is, the way that we categorize this was children that acquired CMV in the first year of life. We separated out those children into those with low viral loads and high viral loads. We took the median of these children, the median viral load value of these children, and separated these out. There's other ways of doing that, but this is the way we tried to do it. And we found some indication of a dose response in the risk of acquiring TB based on those that had higher viral load values were the ones that mostly had higher risk of acquiring TB here. You can see that these had similar here. The ones with higher values were at highest risk, and similar here as well. This is for follow-up that's restricted to after 1 year of age. This is all follow-up. You can see here that the risk of acquiring TB is highest in those with high viral load values. So I think we had this hypothesis. We were a little surprised by the results. They were pretty strong. I think a 2 to 3 times higher risk of acquiring TB is a pretty strong risk factor. But we were a little surprised about how strong this was and the consistency in the results, and that we were able to show a dose response. My experience with epi studies, things don't always work out the way you imagine. So we really wanted to see, okay, what other hypotheses could potentially be explaining this result? Our hypothesis was that CMV is causing an immunological impact in these young kids early in life, and that is what is leading to progression to TB disease. But we wanted to see, okay, what else could be happening? So one was reverse causation, and we talked about this a little bit. Maybe children with very early stage, TB, incipient TB, or very early stage TB, have a different course of their CMV infection, and potentially those children have a higher CMV viral load. So maybe it's happening the opposite effect. Maybe TB is occurring early, we're just not finding it early. And then CMV is happening after or concurrently. But I think this is probably unlikely. We tried to separate out CMV exposure from follow-up further. And we consistently found a similar association here. And the hazard ratios and the relationship didn't really change remarkably. So here you can see, this is the timing of CMV acquisition and follow-up for TB. So we tried to really separate out the exposure and the outcome as much as we could. So this is CMV acquired before 6 weeks of age, follow-up after 6 months of age. We had a really high hazard ratio here. CMV acquired before 3 months of age, follow-up for TB after 1 year of age. Still, all of these were generally consistent. Maybe the most furthest away is this one here at 3 months and before, and then follow-up 2 years and after. Still, it's around 2.5 was the hazard ratio. So still, very high hazard ratio, very positive association here. Our next hypothesis was a common source hypothesis. We thought maybe these children are acquiring both pathogens from the same place. Maybe they're both picking it up from daycare. Maybe a child at daycare or something is giving them both TB infection and CMV. So this is sort of what this hypothesis sort of looks like graphically to some extent. It's a bit simplified, but to some extent, this common exposure setting is causing CMV and it's also causing TB. So we thought if there was a common source of both pathogens, this would be seen in our tuberculin skin test data most profoundly. That if we look at TB infection results, all these kids were tested with tuberculin skin tests throughout childhood. If we adjust for tuberculin skin test results, the relationship between CMV and TB would go away, is what we thought. So if we adjust for this, it would go away. And we found that there was no effect of adjustment for TB conversion. You can see here, this is our base model, hazard ratio is 3.2. If we adjust for conversion, the hazard ratio went slightly up even to 3.7. If we adjust for household TB exposure, which could also potentially be a mediator, the hazard ratio also stayed the same. And I think this was another point, is that CMV was not associated directly with TST conversion either. So CMV was associated strongly with TB disease in our cohort, but was not associated with TST conversion. So we don't think, we think this is potentially some indication that that this wasn't a common source from both pathogens, is what we think, is what this data suggests. So we thought this was unlikely and at least not supported by our data. And then the last hypothesis was potentially there's a common immunological profile prenatally or at birth. So before kids are exposed to either pathogen, that's leading to both pathogens. Maybe the kids that are acquiring both are just more susceptible to both. And so this one's a little harder to study in general. I think this is a possibility. If I'm being perfectly honest, I think this is not a bad hypothesis. And I think you basically need pre-birth data on these kids to understand the immunological makeup to try to really accurately test this hypothesis, which we didn't have. I mean, it's pretty tough to have really good pre-birth data and then follow up like this. So there was no association between CMV and lower respiratory tract infections in any analysis. So this is, we thought this might be some indication, not perfect. Sorry about that. Not perfect, but some indication that at least the immunological makeup of these kids that are acquiring CMV is not putting them at higher risk for other types of infections like pneumonia in this cohort. Potentially there is an immunological makeup that puts them at higher risk for TB. But I think we use this as some indication of some sort of negative control. Not perfect, but. And so we found this really strong association here between CMV and TB. And I think it's important to say, okay, how influential to TB incidence rates was CMV in our cohort? And so really we have an exposure, CMV, that is very common in our cohort. It's around 40% in the first year of life. And then we have this exposure is a really strong risk factor for our outcome, TB disease. And so when you have very common exposure and a very strong risk factor, it's probably not surprising that it was highly influential to the TB disease in our cohort. The population attributable fraction of TB disease attributable to CMV was around 42 to 48% in our cohort, so super high. So big influencing factor. So I think it's important to say that, you know, our study reveals this association. I think there's a lot more work that is needed before this can really be said to be causative per se. And I think the other thing that does not show is a potential immunological mechanism. If there is an immunological relationship here that is happening, so CMV is causing an immunological impact on these kids that is later leading to progression to disease, what is that mechanism? We're not able to show that in our study. And I think that's a really important step before potentially we can say more. I'm not going to go into a lot of detail on this because immunology is not really my expertise. But I'll just go over a really quick snapshot of a couple studies that maybe give some clues here. This is a fairly recent study. This is Ugandan adults showing CMV IgG was associated with TB. In this study, this is CMV antibodies was associated with high serum CXCL10, and they posited that this is a potentially one immunological mechanism. There was also this study also in South Africa that showed that CMV positive infants had higher levels of HLA-DR T cell activation, which has also been shown to be related to TB, and that CMV positive infants that developed TB had lower NK cell frequency, also has been shown to be related to TB. So some potential suggestions of a mechanism. I think we're pretty early days in this general field. I'm running out of time here, so I'm going to quickly hurry. So I think, what are the implications of this work? If this association is found to be quote unquote true, and CMV is a really important risk factor for TB, I think it's important to ask, okay, what are the implications here? And I think there is potential that new interventions could be available for TB control as a consequence to this, specifically for young kids. I don't think we know enough about CMV in adults, but potentially, and this is more theoretical, maybe in my head mostly, but potentially through indirectly preventing or controlling CMV. If CMV is leading to progression to TB, what would happen if we prevented CMV? Would that lead to prevention of progression in these kids? We don't really know. That's something for the future, but potentially it could open up new interventions if that were to be the case. And so here is a recent study in Lancet, I think in 2021 or 2020, that this is a randomized trial in Lancet that randomized pregnant mothers with primary CMV infection to valacyclovir or placebo. And they wanted to prevent vertical transmission of CMV. And this study found a really strong impact of valacyclovir, about a 71% protection of vertical transmission of CMV in these pregnant women. So those children that their mothers took valacyclovir were 71% protection against CMV in early childhood. Another development is that there is a CMV, there's a phase 3 trial that has begun a few months ago. Actually, no, sorry. In 3 days is the completion date, but it started in 2021 by Moderna, trying to prevent CMV in mothers of child's bearing age. This is in several sites all over the world, around 8,000 participants. So there's some research on a CMV vaccine. So just to conclude here, CMV, at least in our cohort, likely acquired through breastfeeding, may be an important driver of really high TB risk in young children, at least from what we see in our setting. We don't really understand the immunological mechanisms of this, although our hypothesis is that there is an immunological impact that this happens through. And if this relationship between CMV and TB and potentially increasing risk of progression to TB is confirmed, it could potentially open up novel interventions to prevent TB in young kids. This was a large team of people. I'm just here presenting this, but huge team of people. And I just wanted to acknowledge them here. Just want to say thanks again to Juliet and Chris and everyone there for this invitation. I'm really happy to speak here today and share some of this work, and happy to take any questions.
Well, thank you so much, Leo, for this thought-provoking presentation, I would say. And I would like to open it up to quick questions. I know our time is almost gone, but please go ahead if you have a question here. Anyone has questions?
I might have missed a piece of information, but how long have you been working on this study and gathering all of your resources for it and your team?
So the study started in 2012, the cohort. So it's been about a decade. And they started even before that, the planning and everything. So around 2010. I started around 2016 or so, maybe around there. So around 6-7 years.
Awesome. Thank you.
Yeah, no problem. Thanks for the question.
Hi, Leo.
Hey, Chris.
I can't resist asking you a question. I wanted to give
Yeah,
other
sure, do
people a
it.
chance to do so. First, I just wanted to bring to your attention our secondary attack rate paper probably does the best job of measuring what the risk of progressive primary disease is following new infection. And as far as I know, we're the only ones that actually showed the match between the index case and the child.
Yeah, no, I know.
So,
of course, I know this paper. Yeah.
Yeah, so we found it was 10%, but
Yeah.
it's very likely that there were other pediatric TB cases that were infected with the same strain as the adults.
Yeah.
That we couldn't get the strains from. So I kind of consider the lower limit at 10%, and in your recent analysis, you got 20%. So I would think it's somewhere in there, in that range.
Was the 10% in what age?
Less than 5.
Less than 5. Okay. Okay.
Yeah.
So yeah, that makes sense.
Yeah. The other high risk group was the young adults, where it was 5% too. So
yeah. So actually, yeah, I think that slightly different rates, but in a sense confirmatory, I think.
Yeah, the shape is the same, and
yeah, exactly.
But it's hard to get sputum and samples from kids and adults at the same time.
Yeah.
I also was really pleased to see that you considered some your alternative hypotheses.
Yeah. I thought you I mean, so Chris was my dissertation advisor, if people don't know. That's partly why I do all this stuff. So go ahead. Sorry.
Yeah. So I'm going to throw some, and I hope it's not a curveball. CMV is a herpes virus. And while I don't think it's, HSV1, which is oral herpes, HSV2, which is general herpes, I don't think that's the issue. But there's another herpes virus that may be lurking, that's Epstein-Barr virus, which probably 100%. Follows the exact same epidemiology as CMV.
Yeah.
So by any chance, do you have the ability to go back and look at Epstein-Barr?
No, this is not a curveball. I really want to do this exact thing. The problem, I think the problem is the type of sampling we did for CMV is through nasopharyngeal swabs, and I think we need a different type of sample for EBV. And there's a lot of stored samples, and so we could potentially go back and look at this, but this is actually something I've been thinking is could it be another viral infection that is also there that co-occurs with CMV, exactly what you said, basically.
Yeah.
And the truth is that is a potential good alternative hypothesis. We don't know.
Yeah.
So I think down the line, we'll see if we can get funding, but that would be a really cool hypothesis to test.
Yeah. The there is literature that TB followed measles in children too.
Yeah.
So, but
interesting.
now measles is not a herpes virus, but obviously it's a childhood. Usually happens in kids who are a little older than
Right.
but within the first 5 years.
It's interesting. I didn't know that. Yeah.
Yeah, yeah, you have to dig it out, and for all I know, it may just be a spurious kind of. So
Yeah.
the last thing I was going to say is that jump at 90 days or so that you see in CMV.
Yeah.
I
I'm curious what you think.
I would postulate or be interested in that's about the time that maternal antibodies start to fade. So I'd be interested in knowing whether the mothers had CMV, and I would imagine most of them did.
Yeah.
And
Yeah.
you know, if they did, they passed IgG against CMV to the baby, and then you know, there's a half-life of 3 or 6 months for a lot of those antibodies.
Yeah.
So
No,
as
this
those
is
wear off, the CMV risk might go up internally.
No, this is a great point too. I think we don't have maternal CMV data, and I really wish, because the reality is, oh yeah, go ahead.
You can go back to them.
I know.
It's
No,
unlikely
yeah, that's true.
that the adults are newly infected with CMV.
It's interesting though, you know, I'm curious what you think, but CMV, we found such a strong relationship between breastfeeding and CMV. But if this is inactivated or like latent CMV, why are they transmitting through breastfeeding so much? If that makes sense, unless they had their CMV reactivated during pregnancy or something like that potentially. But it would be so great to have maternal CMV data. I think that would be so interesting to understand the pathway a little better.
Yeah.
You know, I think we just like we hypothesize this pathway of like mom breastfeeding child progression, but I really would love to have more information to really pad that pathway further, if that makes sense.
Yeah. Studying the mothers would be.
Yeah. No, I think it's a really good point. Yeah.
But
Thanks, Chris.
nice work, just really
Thanks.
great and exciting. We don't understand pediatric TB very well, so.
I mean, yeah, it's an understatement.
Yeah.
Yeah.
So I know our time is totally spent, but Leo, I had just a quick question about, was there an interaction between the CMV and HIV infection co-occurring?
Yeah, great question.
Did you look at interactions for that?
Yeah, we did. So as I said, there wasn't almost no HIV infection in the kids, but with moms, there was some indication, and actually there's a group working on this right now on maternal HIV and CMV that this group is working on now to try and understand this relationship a little better. Yeah, so I think that there is something because there's a maternal or an HIV exposure group that we didn't delve into it very, very thoroughly, because another group wanted to look at that a little thoroughly, and it wasn't the main idea, but there was some interaction there. Not with TB disease, but with maternal HIV and CMV.
Yeah. I see.
Yeah, good question.
Yeah, no, thank you. So any last questions? Anyone has a burning question to Dr. Martinez? Okay, so with that, I want to thank you so much once more on behalf of the Global Health Institute and my colleagues, of course, and our audience. Please, thank you so much for joining us today, and please come again next month, February, and we will have another speaker. So thank you again.
Awesome. Have a great day.
All right, bye, Leo. We'll be in touch.